Alright, so this is important or interesting pharmacodynamics and kinetics, like brief chat part 2. I've noticed when I tell patients that their medications interact, they either say, oh, so I shouldn't take this one, like with this one, or I shouldn't take it together or space it out by a few hours. This kind of confuses me because almost all medications interact with something, and some interactions aren't really direct, they're more of an indirect interaction. With drug interactions, you have to know why it's interacting and what to do with that information. For example, meloxicam and Celebrex, both NSAIDs should not be taken together. Meloxicam is daily, Celebrex is twice a day. Also, some patients be like, oh, so should I take this one a few hours before the other one? And I'm like, no, you can't be on both of them. Another interaction that I see is Paxlovid and something like Xarelto or Atorvastatin. You can't be on both at the same time. You have to hold those medications while you're on the Paxlovid and even a few days after your last dose of the Paxlovid. Again, some drug interactions are by mechanism of action and effect, not a direct interaction in the gut or the plasma to where you can just space it out a few hours. Some do interact like that, like iron or calcium, like minerals with levothyroxine, or tetracyclines like doxy, or fluoroquinolones like Cipro. Those drugs do bind or chelate with minerals, which causes a decrease in absorption and then a decrease in therapeutic efficacy. Some medications require acid for absorption, but some medications actually have a decrease in absorption with acid, like some weak bases like Adderall or nicotine. That's why it's not recommended to drink anything acidic before you use a nicotine lozenge. So again, some drug interactions are by nature of the drug. So let's say aspirin and its bleeding risk. So aspirin binds to the COX enzyme. It's irreversible inhibition. It inactivates the enzyme for the life of the enzyme. So it will have an antiplatelet effect for days after the drug is out of the system. So again, the antiplatelet activity of aspirin will last a few days after aspirin's out of the body until we have platelet turnover. Another example of an interaction like this is with enzyme inducers like carbamazepine or primidone, and how they interact with 3A4 substrates like birth control. Spacing them out how you take them during the day or every other day or whatever will not really decrease the interaction there or decrease the risk of contraceptive failure. Enzyme induction lasts days if not weeks after your last dose of the enzyme-inducing agent. Another example of an interaction is something like Prozac. It has an active metabolite and a half-life of almost a week. So when it flags with other serotonergic medications, again, this is not something that you can just space out by a few hours. The last example I'll mention is with PPIs or Prilosec. It's an acid suppressor. Its effect can last even a couple days after your last dose. So if you're on a medication that requires acid for absorption, you're going to want to talk to your pharmacist. Another interesting pharmacokinetics term is volume of distribution. It's an indicator of the extent of drug distribution into body fluids or tissues. It relates the amount of drug in the body to the measured concentration of the drug in the plasma. An example of a drug with a low volume of distribution is warfarin. It's also heavily protein bound. An example of a medication with a high volume of distribution is midazolam. Medications with a high volume of distribution are usually lipophilic. They're also likely not removed by dialysis. Also, I'll mention that medications with a high volume of distribution are usually not good for bacteremia, so you want that medication to stay in the blood or the plasma. Bacteremia is meaning bloodstream infections. Lipophilicity and volume of distribution are just a couple factors that help play into whether we're going to dose a medication by ideal, total, or adjusted body weight. They also help dose medications in obesity. Pharmacokinetics can differ between patients of different health statuses. Absorption, distribution, metabolism, and elimination can differ between patients not only with pharmacogenomics, but with things like pregnancy. With pregnancy, we can see an increase in gastric emptying time and then a decrease in absorption rate. We can also see an increase in renal blood flow and creatinine clearance, and then a decrease in plasma protein binding. We can also see an increase in volume of distribution, particularly with hydrophilic drugs. Medication management can be incredibly complex with the added factor of carrying and producing a whole nother being. Some drugs move across the placenta, some drugs don't. It's important to note that some animals have more of a barrier between baby and maternal blood, so you need to be careful when looking at animal trials with drugs. I'm not going to go too much more into depth, but I'll lastly mention with lactation, medications that are more likely to be passed through the breast milk are weak bases, lipid soluble, or poorly bound to plasma protein. But yeah, this is why I get frustrated when people say that my job in pharmacist can be replaced by chat GPT, because I'm unable to explain the sheer depth of knowledge and understanding you have to have about medications in order to manage them, especially in complex disease states. It also goes to show what society and culture believe to be what a pharmacist is and isn't, and what their capabilities and roles are.